what I'm going to be doing today is beginning with an overview of where we wound up for the fiscal year 16, again ending 6/30 of this year, give some highlights to that, then highlight our accomplishments since the July, August, September timeframe, so first quarter, and then go to the financial update and talk about the status of agreements. So, this particular time I have divided this update into 5 groups, and I appreciate getting feedback from you. If you think this works, we'll do this going forward. So first off, the status of bringing the data together. Secondly is the status of accessing that data for clinical decision making and transitions of care. Third, the status of our health data management infrastructure, which we've briefed you on previously and relates to what VITL has worked with the state of Vermont in building to support healthcare reform efforts in Vermont. We'll get into a little bit more depth on that later. Fourth, and critically important, is the maintenance of the VHI, the operations of our current activities that often do not get as much focus as they deserve. So we're going to spend a little bit of time on that. And then finally, about a year ago, we began an effort to quantify VITL's work, our impact, our interventions, and we're going to brief you on the early results of that and what we plan to come back to you with in the future. So first I'm going to start off with somewhat of a complicated diagram, and I will walk this through it. So we often, from the Green Mountain Care Board and others, frequently get asked the question about what is the denominator in your work. In other words, how many organizations are left to be connected? How much longer do we need to go? How much data do we have? And we in the state together have struggled with answering that question because there is no one reliable source for all licensed and non-licensed providers in Vermont, for every one and every source that generates data. So today we want you to consider another way of answering that question. And to do so, we're planning to use the Green Mountain Care Board's healthcare provider expenditure data for 2014, which I'm sure you're all familiar with. So this identifies the provider sector's components of the expenditure information. And so related to that, what we have done is look at each of these organization types and identify whether they are directly involved in seeing patients and are generating clinical data, or said another way, can they be connected, or are they potential to be part of the health information exchange? So if you look at the examples, the hospitals are obviously a yes, but things like drugs and supplies don't necessarily generate data, so those get a no. And so then we move the spend related to those that were a yes over into the column C, and we call that HIE related spend. Next, we took all of the organizations that are in our client relationship management system that we've been developing for 11 years, and we identified the known number of sources of data for each yes type of organization. So the hospitals being a yes, there are 14 known primary sources of data. And for drugs and supplies and other services, we gave a yes, obviously, because they were a no. And then we matched that against those that we know in high detail are currently contributing to the health information exchange. So I'm going to walk through an example of that with this next slide. So if you look at the hospitals, there are 14, obviously large acute care facilities generating data. We have all of them connected to the health information exchange. So we are receiving data from all of them, but there are 7 interfaces that we develop with a hospital. An admission discharge transfer interface, a lab results interface. So what we did was a level of detail below this and looked at all the different interface types across all the 14 hospitals, and were able to quantify that 93% of them are actually live and sending us data. So we have about 7% left to go, and that is mostly attributable to continuity of care documents, because some of the electronic health records can't quite meet specifications to move data, and we need funding to be able to do those connections. So we're at 93% for the hospitals. Now, I'll move down to another example that's a little more simplified, and that is home health, for example. There are 11 in Vermont. 5 of them are sending all the data they can send to us. So there, the detail is not as an influencing factor, and as a result, they constitute 45% of the potential home health agencies that could send data to the VHI. We stop there. Does this make sense so far?
So in terms of the other professional services, that would be like PT
Correct.
and some of those kinds of things.
Chiropractors, naturopaths, right.
And are they starting to move to more electronic medical records, or are they still more?
It's highly variable, but we do not have a good sense for how many of them have electronic health records and what kinds of health records they use, whether it's a hosted environment or not. So that needs to be studied. We have a better sense in certain other cases, like with nursing homes or the correction department, for example, Department of Corrections. We know what their status is from an electronic health record standpoint. We just haven't had the funding and haven't undertaken the connection yet, but certainly need to. Any other questions so far?
I guess I'm a little surprised at the hospital physicians at 61%. I would have anticipated that to be a little bit higher, given hospitals only are at 93%.
Yes, so we've had a large movement over the last couple of years on physicians becoming employed by hospitals. So
there's the lag?
Exactly.
Okay.
Yeah, precisely.
What do you mean? I don't understand.
Well, there's a lag in the physicians moving onto the electronic health record of the entity that they become employed by.
Interesting.
So I've got all scripts. The hospital that I'm going to become employed by is on Cerner, and I haven't completely moved to Cerner yet, for example. Another example would be if you look at, let's see, physician services on its own, 14%. So that represents primary care independent specialists who have a lot of disparate electronic health records, so that percentage is relatively low.
And it costs a lot of money to hook them up, right?
It does.
And you fund that, right?
I'm funded by state and federal sources to do that, yes.
But I mean, they don't.
Do we do the work?
Well, you also help pay for the work.
We do. We help reimburse the provider organization to pay the EHR vendor.
How wide does this net go?
How wide does the net go?
The net for the potential of organizations to be connected being the net?
Yes.
Okay. So it is to some extent unknown, to be honest. We certainly can identify, and that's why this particular analysis is one of probably a couple we could undertake, but we don't know right now how many entities in the state of Vermont are generating data on patients. We know licensed providers overall. We don't know a lot non-licensed providers. And don't forget, there are organizations that are generating data on Vermonters that are not in this analysis, like Dartmouth Hitchcock Medical Center. Or we get lab feeds. So a private practicing physician sends their labs out to LabCorp or Quest, a proprietary entity. We have feeds from them. They wouldn't be in this analysis. So there's more data than this analysis is actually representing. So if I go to the next step, I can sort of show you.
Can I ask one quick question from
Yeah.
So I have acronym MIPS on my brain a little bit today for some reason, and I'm looking at this physician services at only 14%.
Right.
So I'm thinking about the requirements for those who, stay in fee-for-service and MIPS, and how that impacts. I mean, would you anticipate a certain proportion of them are all on paper, or you have no way of knowing, or they have just different systems?
It's mostly they have different systems. I think it's fair to say that they all have automated practice management and billing systems. I would say they have a vast majority of them have electronic health records. They just happen to be quite disparate types of systems.
Okay.
But do you have to be hooked up to a VHI under MIPS?
Yes.
Yeah, because it merges all three, right? So
It does eventually. That's right.
Yeah.
Yeah.
What about CPC Plus?
Well, my understanding was that that CPC Plus was not voted positively by the primary care physicians in Vermont.
So no, it wasn't approved by the federal government,
Okay,
but they've announced another round.
okay.
But really, this isn't anything about. I just wondered because the physicians wanted to do it, and what I heard, one of the biggest barriers, when we were at a conference at the Cattle Drive conference, we heard about folks talking about the complexity of the data side of CPC Plus, and I wondered if this was part of that.
It's part of it to the extent that we can take the data from these individual providers and generate reports and quality measures. So I don't know the complete answer to your question yet, and I don't know it for MACRA yet either, because it won't be until the end of December, end of November, I'm sorry, that the MACRA detail will come out for their new 4 levels that they've established. Once we get the data that comprises each level, I can then map it against the VHI and say, on the lowest level, we should be able to support that 90%, or second level, 80%. So that's yet to be determined. We need the MACRA guidelines out there.
This is the best slide you've ever made.
Okay, well, I have one more, so hopefully that will...
Seriously, because this really helps me at least understand what I would refer to as penetration.
Thank you.
Yeah.
Exactly.
I've been trying to understand that, so
Right.
thank you for doing this work.
So one more, Al, and that is, so what we've done to take it a step further then is to say, okay, if they're contributing 93%, looking at the hospitals, I'm sorry, top line, column F,
Yeah.
93%, then we took the 93% as a multiplier of the HIE-related spend and arrived at that 1.983.
Yeah.
And then totaled those up, and that came up to 2.375 billion. And so our conclusion is that the VHI captures data associated with 61% of Vermont healthcare expenditures. So it's one way to look at it in the absence of knowing that ultimate denominator, this is one cut to say, if they're seeing patients and they're generating costs, then we can use that as a comparison to those we know are sending us data.
Just to get a sense of what this would have looked like, for example, last year, what would you, I know you didn't do the slide for, the year before that, say 2013 spend, but just trying to get a sense of what's the trajectory like. What would you have estimated?
I would say it's probably 10 to 15% less,
Okay.
something about like that.
So, not to just go down a rabbit hole, but let's say the state decided to sign a contract for an all-payer model.
Hypothetically.
Hypothetically. Is it 2 o'clock? Well, it's still hypothetical.
That's true.
What has to change on this slide to make that work?
Yeah, excellent question. So we have to accelerate our work from a connectivity standpoint, and we have to increase the engagement that we currently have at the provider organization level. Because it's one thing to get them all connected up, but as we know, and we're going to talk about here in a minute, is that providers are busy, and these EHRs can be complicated, and they don't always enter out the data completely or on a consistent basis. So we need to work with them to make sure that the data is of a reliable and quality level.
So there's training.
That it can be used for analytics. So that's key. So I think those are the two things. Now there's some quick wins I would submit, like for the Department of Corrections. I think we know they're ready. We know the electronic health record is ready to go. We need approval and funding to do that. The tough ones.
Where are they on here?
14%. I don't know, Al. I'm not sure where that they actually reside from an expenditure standpoint. Yeah, I'm not sure.
In an ideal scenario, John, how long might this take?
Well, I don't think we're ever done, Con, because but I would say how long maybe to get to 80%. It's not as much a function of time as it is of resources. So if I
Explain. Don't use words that aren't on a P&L.
Okay. So if I had 2 to 3 times the number of individuals involved in interface development. If I had 3 times the number of e-health specialists, I have 6 that were out in the field helping organizations adopt health information technology, enter data in the right fields, that sort of thing. And then we would need additional resources clearly on the infrastructure side to be able to build this out more. Within a 2-year period, I think we could probably get to 80%, maybe a little bit higher.
So that 14% number seems really low and seems really the
It
most
is.
important number to get to. So of that 80%, what would that 14% number, do you think, with resources that you have,
It's tough.
what would that 14% number look like in 2018?
25%, maybe. Now, I'll throw a caveat in there. If we were able to convince independent providers to use 1 or 2 electronic health records, a common solution, that number would go up significantly higher faster. But that's a tough one. And, specialists, they're the endocrinologist who happens to have his or her unique application that they've been using for years. It's tough to get them to move to something that is probably going to be less tailored to their endocrinology practice, but better for the greater good.
Did you want to answer that, Georgia, about corrections?
Yes, based on my understanding of the way the expenditure analysis is structured, all of the government programs that are DOC, DCF, et cetera, fall under the mental health and other government activities row for your use.
Okay, great.
Anything that I've talked about in the all-payer model agreement is understanding scale. Because scale is a reflection of our belief that it should be voluntary. It shouldn't be a light switch. It shouldn't go too fast. We shouldn't get ahead of ourselves. I'm worried that the scale, like people may want to get in that are not hooked up, and people may not want to get in that are hooked up. And how do we deal with that? That may not overlay very well.
When you say get in, do you mean access to the data?
No, so like if I'm a provider and I'm looking at MIPS and MACRA,
Right.
and I say, you know what, I'm going to join an ACO because I don't want to deal with MIPS, but I'm not hooked up. I have to be able to do the measures for the alternative payment model. And so what do we do about that?
We have to accelerate our work.
Okay.
And I can't do it without the resources.
Well, no, I think they also would have to have the data to do the MIPS because of the,
Yeah,
will.
right, but
They will. Yes.
I want to
They
be
don't join ACO.
yeah.
I'm sorry.
So just to be clear, if they decide to stay in MIPS and they can't meet some of the obligations, they lose money. But if they can't join an ACO and us deem it an ACO and put it under the Vermont model, if we can't report, and so we would want them to hook up for MIPS, but we have an accountability to make sure they're hooked up to be part of the Vermont ACO model. So that's why my question was different. We could spend about an hour on this chart.
it's good.
Wow.
And this was end of FY16, of course, so we will continue to update this as we go through the year.
Yep.
And if the Vermont Care Board would like us to come back and present sort of an interface connectivity development plan, we'd be happy to do that.
Yes.
Yes.
Yep. And I want you to work with the ACOs or ACO and say, I think we have a huge education to do with providers to understand, the reason that I wanted to sign this wasn't, I wanted to sign it because we have this work to do, and so we need to get on with it.
Could I ask you a question related to the funding of the all-payer waiver?
Yes.
Is the funding that the state's going to receive, can it be used for solving this problem? Can it be used for accelerating the connectivity issue?
I believe so.
Okay.
I believe the question is it an IAPD or is it something else? I believe it's an APD.
Okay.
And so in other words, it's not a foregone conclusion, but it means we can apply for it under Medicaid.
Great. Because I would assume it would be for infrastructure development, but not necessarily work in the field with providers developing.
Yeah, so I'm going to say this because I said this to all three ACOs, and I'm going to say it to anyone. I said it at Southwestern when I went down there last week. Don't use any words anymore that don't go on a P&L, because words that the public hates are words like infrastructure, resources. They don't know what we're talking about. You got to say, I need 18 personnel, I need 4 tops, I need 6 whatevers. But we got to get really detailed in the way we're thinking and talking about it, so we understand what the other party's saying. Because I right now understand what you're doing more than I ever have in 5 years.
Okay, great.
So, hold on, Con, we can't hear you. What was that?
I would think, can you hear that?
Yeah.
All right, I would think that an application to Medicaid could go well, given the Fed's sense that this is a project they want to support.
I would agree, but we still have to get it done.
Yeah.
Georgia.
I just want to add one note for the board's understanding, and VITL is well aware of this. In terms of the provider's portion of the expense is for these connections, the provider has to pay their EHR or EMR vendor a certain amount of money, and we are not allowed to use federal funds to pay for that portion of the work. We had a limited allowance under SIM, but from that APD funding you just referenced, that is a non-allowable expense and could unfortunately be a limiting factor in terms of how this chart gets, how we raise what portions of this, depending on which providers are able to accept the financial burden that they bear in the relationship.
How much money are we talking? Do you have any idea? Like to hook up, to improve by 10% in physician services? No.
I would not want to guess.
Let's do that when you come back then.
If I could work with your staff to get the parameters down,
Yeah.
so what's the percentage increase you're talking about over what period of time, then I think I could come back and tell you,
Okay.
Specific personnel, et cetera.
Yep.
Should I keep going?
Yep.
Okay, so I'm going to start off with the first of the FY16 highlights. Going to go rapidly here. Judith is going to do this one.
Wow, tough act to follow. Going from the best slide to mine, but I'll try to do my best here. So I'm really excited, Al, because if you look at the title of the slide, I think I heard you use the term penetration, so I'm very excited that I use the same term here. And I wouldn't expect you to recall, but when we were here last in June, after I presented on my area with respect to VITL Access, we spoke about how I view it by client segment across our entire base. So I use a segmentation approach, and you said I would like to see those results by those segments. So I came back with that information for you this time. So let me just orient you to the slide really quickly so we can make up time here. Going down the left, I have the segmentation categories, hospital-owned practices, and so on. And then moving to the first column, at the end of fiscal year 16, the number of organizations and then the respective organization locations that were live with the VITL Access service. To remind you, these are not data contributors we're talking about. We're talking about the VITL Access secure provider portal that allows a treating clinician to view data. It's not about sending data to the VHI. It's accessing that data that's within the VHI. So you can see those numbers, and then a little bit later on, I'm going to come back with the next 2 columns for you. We're focused on fiscal year 16 right now.
I'm sorry, I have another quick question. The Primary Care Advisory Board met for the first time, and I think someone from your area was there. Yes, thank you.
Yeah.
And one of the areas that emerged was medication reconciliation and the issues of patients coming home or going to a nursing home and all of that. So I just wanted to say that publicly, as we're looking here at the number of nursing homes. But I had no idea, even though I'm a clinician, I had no idea about the complexity about medication reconciliation.
It's interesting you're bringing that up, and Dr. McIntosh, Kate, who I refer to as Kate, did mention that to me after following that. And it's something that my team and I hear a lot when we're out speaking, with clinicians across the whole base, that medication reconciliation is a big challenge. And within Vital Access, there is a query that's embedded in there. That's another source of information that we've received positive feedback from folks about in aiding them in that challenging task. Yeah, it's a constant conversation. Yep.
Okay. So next is Access Today for Treatment Transition to Care. So Judith started that about Vital Access. So a couple of highlights here for you. So in fiscal year 2016, we completed 254 interfaces. So the connections, some of those are inbound, so pushing data to us, 104 of those, and then 150 of them are outbound, so sending data to another organization. So, example, hospital produces a laboratory pathology report, sends to us, we send it off to the nursing home. One other note, event notification service. So we partnered with the ACOs in Vermont. The SIM funded the effort to use data to develop a way that the clinicians can be notified and apprised of events occurring. My patient was just admitted, she was just discharged, just transferred, so that service was stood up. The others are listed for you here. I'm just going to keep moving because of the time. So next is health data management. I'll just touch on a couple of these. We migrated and now host the Blueprint Clinical Data Registry in our health data management infrastructure. That was formerly known as DocSite. You may recall that. Another note, we stood up what's called a Data Mart for OneCare Vermont. Allows their analytics vendor to access data directly on their beneficiary population. It's going to be a critical part of the all-payer waiver approach. And then we stood up two gateways, one for CHAC and the other for Health First this last year, and this will be a conversation with OneCare, VCO, as we decide how they plan to use that technology going forward if they all consolidate. Next is data quality at the source. So this is a lot of what Judith's team does, the eHealth specialists. So we did 100 provider locations, and I've identified the three kinds of consulting that her team does to assist with HIT adoption, meeting meaningful use requirements, allowing providers to attest. Also a big project with Vermont Care Partners, so 16 designated agencies, 5 special services agencies, going back to those who enter the data, make sure they're doing it in a complete, accurate, and consistent way. So this is in line with what we were talking about earlier. So 100 organizations there. There's a lot of information here, so I'm just going to touch on a couple things, but this is essentially what the state gives us, about $4.9 million annually to maintain the VHI. And there are things included in this, such as we have voluntarily decided to a couple years ago, achieve what is known in the healthcare industry as probably the highest level of security for patient data, and that's based on standards promulgated by the National Institute of Standards and Technology. We have a third-party independent come in and review our progress. It's actually the same one the UVM Medical Center uses, and we are right now, as you can see, VITL is currently compliant with 74 out of the 90 controls. And just as a reminder, this is a group of standards that far exceed HIPAA security. So we believe we want to be more secure than any entity in Vermont when it comes to clinical and patient data. And then I just want to note, we often miss the extent to which we are involved in remediating the connections we develop, so the interfaces. So that means that the organization had an upgrade to their electronic health record. We've got to go in and touch the interface and do something to it because of the upgrade.
Like what?
Like what? Christina?
So they may move to a different version, and it may actually move fields around, and there's a standard, and that vendor might not actually be able to meet the standard anymore. So we either have to work with them to have them send it in a standard, or receive the data and manipulate it so that we can now send it on to the other organizations or file it appropriately. That's just one example.
Yeah, thank you.
And so that's a lot of effort. 35% of what we do is remediation. And also remember, every time we touch an interface like that has protected health information in it. that has your and my protected health information in it. So we have to test and validate it every time it's touched to make sure that it's accurate and, you know, we're collecting the correct information. It's a big deal.
Yeah.
Okay, so impact of vital interventions. About a year ago, I signed this task to, I think you know, Sandy McDowell is a PhD in operations research, to undertake an effort to begin to quantify our work. So I'm just going to cover this briefly. This is early. I want you to know that there are, I could probably count less than 5 health information exchanges in the country that are doing this. There are a lot of our contemporaries who say, wow, we're reducing costs. When you start looking at their scientific methodology and their approach, it falls apart fairly quickly. So we want to answer this question badly, but it's not easy. So we started with 2 approaches. The first was to say we want to look at the extent to which practice workflow and staff no longer have to get involved in tracking down lab results, calling, getting faxes sent, waiting for the courier to stop by. And so now having lab results delivered directly into the electronic health record, so they press a button as opposed to spending 20 minutes or whatever searching for the results. So that was one study. And then the second study, which is far more comprehensive, is focused on the patient-centered medical homes in Vermont. And we're trying to identify if there is a contributing aspect between 3 different parts of our activities. One we call technical maturity, so sort of how advanced are they technologically, do they have an interface set up with us. Second, data quality, have they participated in sort of an on-site data quality improvement effort with us. And third is community activity. So has Judah's team met with them once a month, or never, or one day every week, and compare those 2. So that initial results of that analysis I'll get to in a minute. So here's the lab results one. On-site interviews and surveys of 34 organizations, quantifying the amount of time that they are saving as a result of having the data directly in their electronic health record. If we apply it to those that currently have this capability, which are 63 organizations, and the amount of time it's being saved, that totals $343,000 annually. If we apply it to all the universe of organizations that could have this capability if they decided to engage us and we had the funding to do it, which is 149, that savings for that entire universe would approximate $811,000 in savings annually. So this is just one first step of saying, you know, due to Vital's work, you're not spending as much time as you would before. Now we know if a nurse has been spending time doing this and now she can be more involved in patient care, that's a really good thing. And we also know if it saves the nurse 4 hours a week, the practice is not going to be reducing their hours. They're not going to be eliminating the physician. So that's why we term it repurposing. We're not suggesting it's direct cost savings. And in a minute, I'm going to get to the other approach of the study. So that was FY16. I'm now going to switch to fiscal year 17, first quarter, July, August, and September. So I'll continue to try to move quickly here. So a couple things to note, moving down on the page, Vital Access. In the first quarter, we had a 29% increase in the queries of patient data being made by users, and we had an 18% increase in data queries per user. So I wanted to call that out. And then I also wanted to call out down at the bottom, we just finished the second phase of a project to connect up the home health agencies to Vital Access, so 3 of those were brought on board the first quarter. And we also, our team was out at almost 60 clients helping them with health information technology adoption. So, I am now going to turn over to Judith to talk about the survey.
So we conducted a baseline, what we call client listening survey, and the objective was to understand our clients' satisfaction and loyalty to Vital. So we contacted 250, you can see at the bottom, 251 organizations, 68 organizations completed the survey, and that was a 27% response rate.
Who at the organization actually completed the survey? People who use Vital, or who was actually the person?
The respondent?
Yeah.
Yeah, so really good question. The respondent was the highest level person within the organization who has a relationship with VITL or has knowledge of the work and the projects that VITL engages with that organization. Yep, so I'm just going to go over high-level results here. So this is a trust indication. I trust VITL, and you can see the results here by segment across the board. The low end of the scale, a strongly disagree statement, to the high end of the scale, 5, a strongly agree. You can see that the results are very strong, up in the 4 and 5 range. Next one. The second loyalty measurement, I would recommend VITL to a trusted friend or colleague. Again, the same breakdown across our client-based segments at the bottom.
Can I say a question? Just
Yep.
sort of an empirical question, but the 6 that don't know, prefer not to answer, is that included in the average when you're calculating the answer?
It's not.
Okay,
It's
thank
not.
you.
It's a really good question,
Thank
and
you.
I should have pulled it out.
Okay.
It would have been more clear. Yeah.
Okay.
It's just we always have to give an option for someone to say they don't know or they don't want to answer.
Completely understand. Just wanted to make sure
Yes,
that wasn't
and it
driving
was-
up your
No.
your averages.
Really good question, and it's not.
Okay.
It's excluded because it would skew the results. Yep.
Thank you.
Any other questions on that? Okay. Okay, so now we're circling back to the VITL access penetration by client segment, where I just presented to you the fiscal year 16 end results. And now if you draw your attention to the second column, at the end of fiscal year 17 first quarter, we took the same measurement of penetration by client segment. And then the numbers are increasing, but what I really wanted to point out here, which I think is really important for you to understand, is that what we have in flight. And right now, we have several hospital implementations in flight, which is a considerable amount of time, effort, and work face-to-face with the organization. So we currently have Copley, SBMC, CBMC, and UVMMC in flight. And 2 that we just brought live, NMC and NVRH, we bring them live in what we call waves. So the first wave often is central registration, registration within the ED and the ED clinical users. For those 2 organizations, they're live, but there's more work to do. We need to bring the rest of their departments live as well.
Can primary specialty care going down or the number being lower? That's not what's
Which
the
one's
40,
that?
the primary specialty care physician practices.
Yep, so that means 2 organizations are not actively using when they were before. Yep, so that was a drop. a
Any
dip
idea
there.
why? I mean, it seems like everything else is either steady or going up.
Yep, so it's interesting. We actually are modifying our model to do what I call a circle back and to provide at the elbow training for folks. Sometimes what happens is, people hit a bump in the road and, they have questions, and so they may abandon, the use of it. Also, some folks, the smaller organizations, find the collection of patient consent frankly challenging. And so they may say, I'm going to wait and let the bigger organizations do that, and then I'll come back to using it later. So it's a mix.
Okay, now we're going to jump to the health data innovative search. And Mike Gagnon, our CTO, is going to lead us through this.
Yes, thank you. I'm going to go fairly quickly through some areas that might need some further explanation later, but we have only a few minutes, so I'm going to try to move pretty quickly through this. About 2 years ago, we recognized, partly because of the Blueprint for Health, that we were going to need to take the data that we're using for clinical care and start to make it available for others to do analysis. And when you get into that, it's much like building a data warehouse at a large medical center. You got to make that data ready to be analyzed, and that's a bunch of things that have to happen to make that work. And the Blueprint exposed what those are, and that is that data is often incorrect or missing from the interfaces that we get. The patients are not matched across all the care settings, and so you don't know this is the same person. It's not in a format that can be used for analysis. It's in a format that a human being or a doctor can readily view and look and make sense of, but it's not really ready to go. And then it's not standardized any national terminology standards, and I'm just going to give you a quick picture of what kind of normalizing that looks like. We get in all kinds of blood sugar tests called glycated hemoglobin A1C, hemoglobin A1C, and a variety of names for what is effectively this standard code 4548-4. And what we're putting in place a thing called Terminology Services Engine that can first guess pretty good at how to make those all to the standard. And the other is it can actually create a mapping table so the organizations can tell us what those are. And so this is something we just put in place at the end of June. We're starting to work with the EOs and the blueprint on now. And we're going to make continuing progress on improving the data that's there for analysis. There's a whole bunch of others, by the way, we do this with meds and allergies and problem lists, and the list goes on and on. Going the wrong way. Just an example of some of the ACO measures we've started to pull together. This is a typical ACO measure where they need hypertension and they need their blood pressure and they need, there's various things they need to do. And here is where we collect that data from the interfaces we get from the electronic health record, either in what's called the continuity of care document, care summary, or in an ADT or in a lab test. And so we have to extract the data from those interfaces and then make it available. As John mentioned, we're doing this data mart for OneCare. We put the data into an individual field so they can actually analyze that information. And that's a fair amount of work.
This slide is the slide that everybody who doesn't understand what we're talking about needs to see. I mean, this is like, people don't understand. And I'm not saying they don't understand what you just said. They don't understand that you can do this. And that's a huge problem. In all the public forums we had, there were a lot of questions about who are you measuring? What are you measuring? Who measures it?
And there are hundreds and hundreds of these elements in there that we need to get ready for the ACOs to analyze.
Right.
And one of the other things we need to do is then work with those medical practices to make sure that if they haven't put the data in their electronic health record in a way we get it, that works as well. And so we started doing something called the data quality report. It's kind of like a scorecard for that practice to say, how well are you meeting the ACO measures? How well are you meeting the blueprint measures? Do you tell us the information? Is it coded right? So this is just an example of one page of a multi-page report from Thomas Chidden Healthcare that says, this is how well you've done in coding your diastolic, basically your blood pressures, in your diagnosis of hypertension. And so now we have that ability to extract that information and make it available back to them to tell them how well they're doing.
So it's sort of we'd like to think of it as a circle, working with the source organization on the way they enter the data, working at the network level, as we were talking, Mike talked about the standardization, normalization, and then being able to send reports like this back to the provider organization, almost like a report card, and say, here's how you're doing, we need to do better.
Yeah, but we've got to make this a public thing, meaning that this is your value equation.
Yeah.
One of. I don't mean
Absolutely,
but
right.
I don't mean to be rude like that, but I mean this is a huge thing that people really wonder about, patients really wonder about. Like, what do you mean you're going to measure something? What do you mean by value? We should talk about that.
Okay.
Meaning over the next year, we've got to, everyone wanted public forums before we signed the agreement. I always thought the public forum should come once you're trying to work on implementation. So we have to figure out how to do that and tell everybody's story that's a part of this.
So the other important slide I got to that is 26, because on page 26, as a clinician, you see all the ways people call the same thing something different.
Yes.
And
Right.
that is seems to me huge. So I think that's really important.
I would agree.
Yeah,
I
it's
just
a big
have-
effort.
Yeah, I have one question about how, let's say they're not recording a diagnosis in this example.
Mhm.
How do you catch that? Is it because you have other pieces of metric like the systolic and diastolic that include you that it should have been reported in a certain way? I'm trying how you find the blank.
Let me give you one example. For example, if you did not record a diagnosis of diabetes mellitus, you could say, but the A1C test was over 7. That person has clearly got diabetes. So you could infer from that information things. So you can build business rules into this to make inferences about what's going on that include a kind of more holistic picture of all of the information that you have on the patient. But sometimes you just don't know until it is coded, right? And then you just work on the fact that the diagnosis is not present in the message, and then you work with the practice. So you have to create this, as John said, this feedback loop continually around, all the way from the ACO to the practice to us and back again, and all through that to make this work.
Yeah, I mean, what I think is that, as part of the club that gets beat up on certain news sites, I think that, this is the best communication I've heard from your entity, team communication. And if we could take pieces of this that are for the public and really explain to people why this is going to help them be healthier, it's just going to be very powerful. I mean, it's what we've all been working on for years to try to get to this point, and it's just great to see it in your presentation.
Great. Thank you.
Thank you. There's one last slide quickly.
Yep.
So we've been building this for 2 years.
Yeah,
Building
exactly.
Pieces of this for the last 2 years in order to support the blueprint and ACOs, and now it's a very advanced capability, and only a few other HIEs in the country have been close to this now. I'm not saying individual medical centers don't do some of this, but they don't get a statewide view of an entire population. And that makes it a much more challenging impact. Look at all the interfaces it takes, and look at all the data you get, look at the variety of different kinds of data quality you get in that environment. It makes it a more challenging environment. And we're prepared to augment this with claims and other sorts of information. We're ready and have been ready for a while now to think about how to do that and how to make this really the truly data set that would do full population health data analytics and care management.
Mr. Chairman, do you have a hard stop here at 2? Because I'm trying to gauge based on what we have 11%.
Well, we have recess at 2:20, and there's never been recess on our agenda before. And so, I was thinking kickball.
Maybe I'll do snowball play.
So what we do have a hard stop on is probably like 2:20. Gives us time to set up, because the CON hearing has to start at 2:30. It's a warned hearing, so we got some time.
Okay.
So roll tide roll.
Thank you. Okay, so I'm going to finish up here with first quarter FY17 and come back to the impact analysis work we've been doing, and then get to the financial update. So in this particular aspect of that impact study that Dr. McDowell's been working on, we are looking at patient-centered medical homes, and we use a lot of the research methodology approach that the Blueprint for Health has used in the past. And essentially what we're trying to figure out is whether or not there's a difference of differences between a patient-centered medical home that is interacting with VITL on certain aspects, like, as I talked before, technical maturity, the data quality interventions, versus patient-centered medical home that is not. So this is based on claims data from OnPoint, and the early result is that if a patient-centered medical home completed a data quality sprint, and what is that? It's essentially winds up frankly being a little bit more of a mini marathon, but what it is high-level interaction between the Blueprint and VITL folks and the particular patient-centered medical home to improve everything from data quality to looking at the interfaces and just spending an awful lot of intense time to ensure that they're using the systems correctly, the data is getting entered, it's usable, that sort of thing, versus one that doesn't. And so, again, those that had completed data quality sprints also had lower expenditures of $357 per capita per person. Now, that's a significant
per what
number.
Time period?
That's a huge number. Over what time period?
Per year.
So we're not suggesting that this is the sole driver to that $357 savings, of course, and that's some of the more work we've got to do to take a look at what the other factors are. But it's an early indication that if they're more technologically mature as a result of this data quality sprint work, then that has a potential relationship with the cost of care. And that went also for the second, which is related to the technology maturity. And for those that had a higher degree of maturity on that scale, also had lower expenditures per person and also associated with fewer ED outpatient visits. So this study will continue, and we'll be coming back to you over the months ahead as we get more results. I would just like to make note that we are very interested in accessing the VCURE's claims data so that we can expand and improve on the results of the study, and would appreciate your help in being able to do that. Can we move to the financial update?
Yeah, do we want to talk about that at all? I mean, it's just a data use agreement, right?
We're actually speaking, I think, with Roger.
Roger is not.
Is that right?
And he's not in today, so.
Oh, so then I can just approve it now?
No.
Sure.
Oh, I can't? I can't?
Just get your signature, yeah.
No, just the DUA is in the process. I've spoken with Roger about it.
Okay.
Okay. So I'm going to turn it over to Bob Tourneau, our CFO.
Good afternoon.
How are you, Bob?
I want to begin my discussion.
Yep, got it.
I want to start with a chart that we looked at the last board meeting. This is a timeline of current contracts or grants that VITL has. And I want to start with the DIVA contract. We have really, I think, a good news story there in that through collaboration with the state and VITL, the DIVA grant was signed or awarded on July 1st, which was its earliest that it's been in several years. We appreciate the effort from the commissioner, who personally sat down with John and I on June 30th, and we quickly arrived at an equitable solution. We hope that this could be a model for future contract negotiations. We appreciate the hard work by Georgia Maharis on our behalf to make this happen. However, we still have a large nugget here, which is the resolution of the indirect cost proposal that is out there, and I'll talk a little bit more about that in a couple slides. Moving on, I want to talk about the SIM contract. We received an award on June 20th. That was for 2 line items that totaled $500,000. We received another amendment at the end of August for 7 more line items. Of those line items, a value of about $530,000 was for work that we had actually completed on June 30th. So,
Can you speak up a little bit?
Sure, Con. Sorry about that.
No problem.
The point here is that of the $1.3 million in that amendment, roughly $530,000 was for work that we had completed on June 30th. So we are expecting another amendment to the SIM contract. That's going to cover the phase 2 of the terminology services project. As you can see, that our contract for the SIM contract ends December 31st, so our expectation is that the amendment will extend that contract length through June 30th. Also, we should note that we received a contract for the summit. That was received on October 4th. That's not included. There will be a follow-up amendment to that because that will come out of the $4.9 million budget for the DIVA grant. So there's a portion of our work which was deemed not able to be funded under federal money, and that was the summit. So that was pulled out. And so there'll be an amendment at some point in the near future to pull that money out of that $4.9 million. Moving on, we have, we understand that the feds approved the APD contract. Unfortunately, we don't have a signed award, and so 32% of our performance has expired. Next slide. So next, I'd like to discuss how all these delays of the awards of contracts affect VITL. One of the largest is the hit to our cash flow. We can't bill for work that's done, and it necessitates us to go out on risk and on VITL's dollar to ensure the continuity of certain critical projects. So VITL's cash is constrained. Our current projection is for 12 days of cash right now, although we expect several invoices to be paid by the state in the near future. Yeah, that's 2 weeks worth of cash. This impacts our ability to get our work done because we're only willing to go out on risk for our own labor. We don't engage vendors in a contractual arrangement unless we have funding. And also, we're not currently bringing on budgeted staff because of this. An example of how this impacts our program is the lost opportunity on the Department of Corrections project, on the APD contract. The Department of Corrections and the vendor are ready to engage us to build interfaces, but we don't have funding for that through the APD contract because it hasn't been awarded. So that work is not going forward. So what that means is that the DOC is unable to receive results from 14 hospitals on their priority list, and they're unable to contribute information to the VHI. A major challenge to VITL is working through the new requirement from the state for an indirect rate methodology. This is the first time that the state has required an indirect rate methodology from VITL. Since our proposal was submitted in July, we have submitted almost 53 megabytes worth of data to the state. We had initially expected that the review would take 60 days or be completed by the 30th of September. We are now looking into November right now, and the review is still ongoing. It affects us in two ways. Our cash flow is constrained because we can only bill at our expenses plus a provisional rate of 10%. That would be a provisional indirect rate covering our indirect expenses. And that's well below what our actual rate that we're running at, which is about 43%. In addition, there are over $500K worth of funds from FY16 which haven't been recovered and are dependent upon the completion of the state's review and negotiation on that indirect rate proposal. The completion of our audited financials are also dependent upon this review. So the last time we were here, there was a request by the board for what was VITL's quarterly spend. Our budget, as I mentioned before, was $4.9 million. To date, we have spent $1.355 million, or 28% of that available budget. Yet we're only able to bill $1.1 million using the provisional overhead rate of 10%. So that leaves us with $300,000 of cost, which we haven't recovered. To survive this situation, we have limited our expenditures both in labor and vendors, and this has impacted our ability to complete our work. So to conclude, in order to keep the important work of VITL that performs part of Vermont health reform efforts, we respectfully request that the award of the SIM amendment and the APD contract, along with the conclusion of the state's review.
Can you repeat that, Bob, please?
Sure. Sorry about that, Con. We respectfully request that the state, that the award of the SIM amendment and the APD contract, along with the conclusion of the state's review of our indirect rate, be concluded by November 15th. And that's all I have.
So have you sent a letter to the administration saying that?
No.
No.
We have not.
Okay. And Georgia, not to put you on the spot, but is there any news to update?
I have some news to update. I think the board is aware that DEVA also had an audit by the state auditor throughout the entire summer, and that made some significant recommendations. One of the dynamics of that audit is that our finance team frankly had to do a significant amount of work in response to that audit concurrent with the work on VITL. And what we did is we prioritized execution of agreements so that we could get as much money flowing to VITL as possible to alleviate the cash flow issues. My understanding is that over the next 2 weeks, we will have resolution on the indirect rate and some other outstanding issues that we've been working on with VITL. Then subsequent to the indirect rate being modified, we then have a slew of contract amendments. Bob referenced a couple of them. I provided a chart to Susan that showed just we basically have to modify every agreement to make sure that they're all in compliance with the new indirect rate. And our intent is to do that concurrently so that all of it hits basically at the same time so that everyone can see all the dollars moving between agreements and the new indirect rate being put into effect. I would also just acknowledge and appreciate the work of VITL in providing the state with the documentation for the indirect rate. I think, unfortunately, this is an area where, frankly, we were out of compliance with federal guidelines. And so we have to get into compliance with federal guidelines or it jeopardizes our ability to use federal funds. And unfortunately, the process requires an inordinate amount of detailed information to justify an indirect rate that is above the de minimis rate of 10%. So thank you to VITL for working with us on that. I know it's, my understanding is that the way the data gets released from your system is not necessarily as easy to kind of pull out. Ironically, the financial information has to be translated, much like the clinical information for use for the indirect rate analysis.
What do we have on the 17th of November? So we should hear back from you on that day and where you are. Because if not, then we've got a note. I mean, I think we've got a responsibility to say something.
Okay.
Yeah. Okay.
I agree, Al.
Okay. Thank you, Con.
That concludes our presentation this afternoon, Mr. Chairman.
Well, it was an excellent presentation. It was really,
thank you.
really, really well done. Does the board have any questions they haven't asked yet?
I do not.
Just a comment on my end. John, I think you got one of the toughest jobs anywhere. And you keep coming back with almost a smile on your face. And you are making progress. But this financing thing could kill it. So we understand how important it is.
Thank you.
Mr. Chair, I have one additional thing, and I apologize for not stating it. John, you didn't go over this in your slides earlier, but you referenced this infrastructure work. And so one of the things that I think we've improved on with VITL is really getting ahead of needs, particularly those that require additional federal approval, so that we can see 6, 9, 12 months out, so that we don't have delays in contract execution because we're waiting on our federal partners. So I, again, want to thank VITL for their work on. That's just one example where we've implemented that process, and hopefully we'll continue to do so that we're getting ahead of those areas where we need federal funding.
Thank you, and I think the board should know that we've also obviously been working with One Care Vermont predominantly over the last, at least a year, specific to the SIM work and the funding there, but have accelerated that engagement here recently in anticipation of all payer waiver approval, and are working together with them and the state to come up with sort of the plan from a technology standpoint going forward.
I have no questions other than I'm glad we'll be taking this up because I worry about everybody's coronary arteries when you have 2 weeks cash on that. So.
Yes.
My only thought is that I'm looking forward to hearing that plan, in terms of the penetration and scale.
Yeah,
so
absolutely. Yeah,
that'll be important.
Look forward to it as well. That's thank you for letting us come back with a plan specific to that. So.
Yeah, I want to do that, and on the 17th, we might be able to talk, we can keep talking about this stuff. The key thing I want to know on the 17th is, are you okay? So hopefully we'll get some movement on some of these issues.
Sounds good.
All right.
Thank you.
So I'm gonna take a moment, and I'm gonna open it up for public comment or questions.
I just had a comment. I just wanted to say thanks to Al for trying to make sure that VITL and everybody reduces all this to the common language. That's highly important, and I get that all the time.
Yeah,
Comment.
I just wish we had those 2 slides with us at the public forums. It really would have been amazing to show people. We tried to talk to it, but pictures. Yeah.
10,000 words, and
Yeah,
still nobody understands percents and this and all that.
that's right.
Grant FY 17.
Yeah. Yeah, I've learned if you put FY in anything, you just.
I do understand it that way.
Has anybody seen my quote in the Washington Post?
I didn't know.
The guy said, "So you just agreed to take on this big challenge?" I said, "Yeah, I feel like I just signed up to paint a really, really big house."
Yeah.
So thank you, Walter. Dale, I think your question is going to be much harder than that. That's why I picked Walter. He might not have been faster. Go ahead, Dale.
I had to chuckle as I was writing this down because it's like, okay, use plain English. My first thought was a p-value for data so that we know it's ready to go for NIPS. I'm referring to the reliability of that
Yeah.
because I think it's really important that for what MIPS is, I know Betty put, but I think even from a consumer point of view, it's easy to understand how significant that is, that it's going to have a huge impact if it's not ready in the way it needs to be. It's got to really be reliable. The other one was sort of similar. You got over $1 billion, if I understood right, that's not accounted for in terms of money that has no data attached to it. You go back, it was in the first
I got you.
slide.
Keep going.
Versus something else. I thought I saw $1 billion that there's no data for.
Mhm.
So that is pretty significant in terms of my overall picture to have $1 billion out there that I have no data for. I just wanted to highlight that. The other one was, I think I heard, and I would just reaffirm that I think the consumer can get this, that you can't move the all-para model faster than the HIT that backs it up for the healthcare information. I think that's a really strong point that would be to try to put the cart before the horse. And I can't help but wonder if we shouldn't be making that absolutely clear to everyone that's talked to, because they aren't exactly have this great view of HIE, especially with the exchange. I mean, a lot of people out there have a bad feeling about it going forward. So that's another reason I brought that one up. I think the consumer has to be fairly treated for the experiences they have to understand what this is and how it is going to be a good experience and not a bad experience. And let's see, what else? To factor in the cost of the HIE or HIT itself, you get the $357 per person, because that question will get asked. How much did I spend to get my savings? And so I just want to highlight that. And then last but not least,
He's so good.
I'm not sure consumers measure HIE in the same way that we're talking. As good as this is, I'm more interested when I walk out of my doctor's office, what they hand me as my summary, what that has for data. Can I walk into my pharmacy or can I walk into my physical therapy and hand it to them and say, everything you want is right here? Or can they call it up on a screen? That, to me, is information working with me and doing what I needed to do. I'm just saying.
So
probably think of it, measure it differently.
yeah. So you know what's fascinating, Dale, is first of all, this may be your best day as a season pass holder, because I mean, I couldn't write fast enough. One of your quotes we need to put in our annual report. Seriously, did you write it down?
I was just saying you're an honorary economist too with your cost benefit.
Dale will have a plaque up there too.
I want to say something, and I'm glad that it's not in public because I wouldn't want anyone to hear it. No one should have ever known about Vermont Health Connect. Ever known about it. Anybody here use a credit card? Other than Sandy, who's smarter than like all of Montpelier, does anyone here know how that system works? Seriously, like you put it in the gas pump and you pull it out and you stand there watching Jay Leno on TV. You're not thinking, God, I hope Visa works today. It just works. Vermont Health Connect taught people something they should never have known about. And I don't mean to hide it from them, and I don't mean it in an evil way. But these things, to Con's point, I'm glad you're still smiling because these things are getting all churned up in the same washing machine. And so you cannot do health reform without the stuff that we're talking about. If you think about it in a military sense, it doesn't matter how many tanks or bullets you have. If you do not have diesel, you are not going anywhere. Okay? And so your points are just dead on. But my fear is that Vermont Health Connect has tainted this whole conversation so that people are afraid to use their credit cards. Do you want to comment on that, John?
Sure. And there were a lot of really good points made, and I could take 3 days to talk about it. But I think that I completely agree. And something that the consumer population, unfortunately, does not realize that I think now is becoming more apparent is that healthcare has been so far behind from a technological standpoint, and I don't mean clinical technology, which I think of more like everything from EKG to 3T MRI, but the data part. And because of the expectation you just suggested, is they expect things to work as they do technologically in normal day-to-day life. But healthcare is just catching up. And I think we've made great strides here. We have a ways to go yet. But the complexity that, frankly, goes all the way back to not having standards and common specifications among the systems that capture the data. We are still dealing with that. And that was solved by other industries right at the inception. So I think it is something that has to be communicated to the public. I think we're making good strides. This is critically important for their health and not just the cost of care. So anything that the Vermont Care Board can do to help explain this, we struggle with it sometimes because it's so complex, but I think it is an excellent point that the expectation the credit card is going to work is not the same expectation the electronic health record systems are going to work.
That's right.
What I'm going to be doing today is beginning with an overview of where we wound up for the fiscal year 16, again ending 6/30 of this year, give some highlights to that, then highlight our accomplishments since the July-August